Good morning, and welcome to our weekend webinar on the basics of neuromodulation. My name is Josh Lucas. I'm a fourth-year medical student at Drexel University College of Medicine. I'd like to first thank everyone at the Medical Student Neurosurgery Training Center, as well as Dr. Dorian Cusick, a fifth-year neurosurgery resident at Allegheny General Hospital, and then Ben Sherman, who's a second-year medical student at Drexel, for their help in organizing this event. So today I have the pleasure of introducing Dr. Donald Whiting. Dr. Whiting earned his undergraduate degree from Grinnell College in Iowa, and then went on to earn his master's in physiology at Georgetown University. He was awarded his medical degree after training at Thomas Jefferson Medical College in Philadelphia and completed a neurosurgical residency at the Cleveland Clinic and a neurotrauma fellowship at Allegheny General Hospital. As Allegheny Health Network's chief medical officer, Dr. Whiting is Allegheny Health Network's senior most clinical executive and the leader of Allegheny Health Network's medical staff. He is also president of Allegheny Health Network's physician organization, the Allegheny Clinic, which is one of Pennsylvania's largest physician groups, employing more than 1,400 physicians. Dr. Whiting is a respected physician leader who is passionate about changing the way healthcare is delivered. He is regarded as one of the nation's foremost experts in the use of deep brain stimulation to treat patients with Parkinson's disease and other movement disorders. In doing so, he has helped establish Allegheny General Hospital as one of the top centers in the world for DBS treatment. Dr. Whiting has served in numerous physician leadership roles over his two-decade affiliation with Allegheny Health Network. Most recently, he was assistant chair of Allegheny Health Network's Neuroscience Institute, as well as chairman of Allegheny General Hospital's Department of Neurosurgery and co-director of Allegheny General Hospital's Division of Functional Neurosurgery and Neurosurgery Spine Biomechanics Lab. Dr. Whiting is a professor of neurosurgery at Drexel University College of Medicine and an active member of the Congress of Neurological Surgeons, the American Association of Neurological Surgeons, and the American Society of Stereotactic and Functional Neurosurgery. Please welcome Dr. Whiting. Today, he will be giving a talk on the past, present, and future of neuromodulation. Please feel free to type any questions you may have using the Q&A function throughout his talk to be addressed in the Q&A portion at the end of his talk. Dr. Whiting, when you're ready, please feel free to take over.
Okay, I'll start sharing my screen, but thank you, Josh and Ben. I'm a little embarrassed with all of the stuff that Josh said. It just seems like exhausting to hear that. So I don't think my talk will be nearly as good as the introduction was by Josh. Also, I just think it's amazing what the training center group is doing for all of the med students to really get you the education, the experience, the feel for what it is in neurosurgery before you make those kind of decisions, while you're making those kind of decisions, because I think it's, I was just talking to Josh yesterday about this. It's a long residency. It's a long career. It's something that you have to really know what you're getting into before you get into it, because it's a commitment for life. But on the other hand, it's the most amazing thing you can do as a career. I think I'm obviously a little biased, but I truly think it's the forefront of where we can truly change how we're delivering care, how we're, just brain machine interface technology, computerization. There's no other medical specialty that has anything as cool as that going on. So that's just my plug for the job in general. I think it's the best job ever. The more, we can help you all get comfortable with the idea this is the way to go for your career, the more we like it. But so what I'm going to focus on now is really just giving a little bit of a history of neuromodulation and go through where that's been, where that's headed. And obviously for you all, where I say it's headed is going to be the standard for when you start, and then kind of the sky's the limit beyond that for your careers in this business. And then at the end, there'll be time for questions. I think this isn't really meant to be so didactic. It's more meant to be exploratory. If I was going to really talk truly about this thoroughly, it'd be a 4-day seminar. So I'm just going to kind of hit highlights, give you a little bit of a history, and then kind of go from there. So first of all, what exactly is neuromodulation? Well, first of all, I have no disclosures at all. But a couple of things I'm going to talk about are going to be off-label. Functional neurosurgery really means restoring function. And, pretty much very liberally, that's what everybody in medicine does, is restore function. But we're really doing it at the neural level. So, unlike stroke, where you treat the stroke, do the carotid endarterectomies or aneurysms, fill up the aneurysms. Those are all things. But in functional neurosurgery, we're taking people who have some deficit in their day-to-day function, generally with intact cognitive function, and kind of restoring control to them of their body. So Parkinson's, for example, that's an abnormal firing of rigidity circuits in the brain that keep agonistic and antagonistic muscles working in a non-synchronous way. So your brain says what to do, but your body's not listening to it. And so we go in and sort of recorrect that kind of thing. So that's generally what functional neurosurgery is. It does involve pain, movement disorders, and epilepsy. Honestly, sometimes people throw in radiosurgery to some degree too. Certainly for radiosurgery for movement disorders and things like that, it would be. So really, functional neurosurgery is restoring function in otherwise non-functional components of the neural axis. And that's what we specialize in. In general, the good part about this part of neurosurgery is it's very tech friendly, and we're in an explosive time of tech advancement. Frankly, 10 years ago, I was working with people at Carnegie Mellon, and they had computers that were 2 millimeters in size that could be connected to sensors and effectors and potentially be all completely closed loop style implanted under the skull. Their heat generation, there's some other issues that there were issues with that, but the technology is moving very quickly, and how we connect that to physiology gives this particular part of neurosurgery a really exciting future. So that's kind of my pitch for this, for you guys, for your career. But let's just start with pain as an example. So pain, in pain, the functional component of pain, functional neurosurgery component of pain, is electrical, but also medication related and ablative. So there, with all of functional neurosurgery, it kind of started out with ablation, where people would either on purpose or inadvertently create lesions along the neural axis and get some change. So that's actually how the thalamus, lesioning of the thalamus or the subthalamic area, those areas for movement disorders were discovered was inadvertent strokes, inadvertent ligation of vessels. And then people saw that and then extrapolated from that. So lesioning kind of was the beginning of all of functional neurosurgery. The trouble in general with lesioning is that it's a point solution in time. So when you lesion for progressive disorders like movement disorders, you've kind of maybe solved the problem then, but as the disease progresses, you kind of lose that benefit and the symptoms come back. So that's where neuromodulation kind of got more of an interest, because it's reversible, it's adjustable, it's adaptable, and it can change with time. And that's where electricity became a big part of functional neurosurgery gradually over time. But also with pain, I'm not going to talk about it today, but pain pumps, intraspinal use of medications is a big part of neuromodulation. And overall, implantable devices, pumps, and stimulators for pain make up about 70% of functional neurosurgery implants. So overall, that's the majority of the implants. With the difference of when you would use a pain pump or intraspinal medication versus stimulation generally revolves around whether it's somatic pain or neuropathic pain. So somatic pain with the opioid receptors in the substantia gelatinosa area, that was actually a discovery in the 70s, the 1970s, that there were opiate receptors in that area that would affect somatic pain. The beauty of intraspinal and central narcotic medication, morphine usually, is the most common one, is that it has about 100-to-1 ratio of efficacy versus side effects compared to oral. So it's much more effective with lower side effects at lower doses. So that's why really in the early 1900s, intraspinal use of analgesia was first experimented with cocaine, and that gave a nice intraspinal block. And then morphine was added to that a few years later, but it really was about 70 years before people figured out about the opioid receptors in the substantia gelatinosa in that area, and started really looking at intrathecal narcotics for cancer pain. And most of that was done in a sporadic dose type of style until about the 1980s, whenever continuous intrathecal infusions were started. And then the late 1980s is when morphine pumps started coming around, and now there's different medications that you can put into those pumps. So a lot of the technology that we're doing today, both stimulation and pumps, really became used as an implantable device in the late 80s, early 90s, and has taken off over the last 30 years. So it's a fairly young field, functional neurosurgery. At this point, with and this is the last thing I'm going to talk about pain pumps, and then I'm just going to move to electrical because that's more of what is the trend now. With the pumps, the implantable pumps, the main indication for the pumps at this point really is cancer pain or somatic pain. So pain that is based in bone, muscle origin, that opioid receptors will be effective for, that's the kind of treatment that's best for. Typically, if somebody has cancer pain but a life expectancy less than a year or so, you'll go with more of a continuous infusion rather than an implantable pump, just because the risk benefit and cost benefit ratio isn't necessarily there. But in general, if you think cancer pain, then the implantable medication pump is the way to go. And that's really the main indication right now for implantable pumps. Just to close the door on ablation to some degree, ablation these days is typically reserved, although it was the mainstay for a very long time, it's typically reserved at this point for someone who has a chronic infection where an implantable device can't be implanted, where you have to have something that's not implanted. Cordotomies, cingulotomies, things like that are things that I kind of grew up doing that are very effective, particularly for non-progressive diseases. So chronic or severe pain from, cancer, chronic infection, chronic fractures, things like that. But it's not really something we do routinely anymore, because the beauty of the electrical delivery of pain and epilepsy and movement disorder treatments is that it's something you can get in, put in, take out if something gets better, because it's non-destructive, so it's reversible. it's a device like that, but also it's adaptable over time. So as things change, as things progress, you can modify it just by simple programming changes that are becoming easier and easier to do with more and more options. And so that's really the growth area, is the electrical part of what we're doing. So I just wanted to touch on pumps. I want to touch on ablation a little bit. And all of this is really based on more and more progressive scientific evidence to validate it, because a lot of it that in the late 80s, early 90s that we had to go on really was anecdotal experience. And that's really what I think is the best part of functional neurosurgery is, I can write an IDE, a physician-sponsored IDE about doing just about anything to anybody with neuromodulation, and the FDA is going to approve it. We've done that for a ton of things, and because it's a relatively safe modality. It's the safety profile for stimulation of all types is very, very good. And it's reversible. So you're not doing anything that's necessarily highly risky. And it is, you try it out. If it doesn't work, you take it out. So it's a really, I can't emphasize enough what a cool time it is for functional neurosurgery people to be able to develop and experiment and do new things. So there's just a lot of future there. Getting back to functional neurosurgery for spinal cord stimulation. Spinal cord stimulation is really the mainstay of pain modulation, particularly for neuropathic pain. And when you go through the treatment algorithm in general for a patient for pain, basically it starts out with the usual stuff: oral medications, therapy, treating the cause of the pain, all of those kind of things. But when you're left with chronic pain and non-correctable chronic pain, then typically we'll go with a spinal cord stimulator first, and then we'll go with a morphine pump or some other drug pump as the next thing down the line. Because with the stimulator, there's no refills, there's no risk of overdose, there's no medication changes. It's just more of a long-lasting, robust kind of device. So that's kind of the general algorithm for patients. But using electricity for pain isn't really something new. Actually, in 15 AD, people were using torpedo fish, which generated an electric charge to treat pain. And I have no idea how they were doing it or why they were doing it, but they're back in AD 15 AD, that was a thing. Ben Franklin, does what a lot of kids in the country do probably now just for fun, and he got sort of credit for being a great scientist. He figured out that electricity would make muscles twitch. So he was using that to make muscles twitch. Mary Shelley, the Frankenstein, novel, electricity to make her monster come alive. There's just a lot of interest in using electricity within the neural axis to do different things. But it wasn't really until 1965 with the Melzick and Wall gate control theory of pain that this really had some science behind it, and really got really around where we could start studying in an organized way, following pathways, doing different things. And y'all probably know the gate control theory, but the way I explain it to patients in a very simple way is that the proprioceptive pathways of the spinal cord are very fast pathways that go very quickly to the brain. So proprioceptive and balance type of things, vibration type of sensations, travel faster than pain fibers. Proprioceptive fibers in the posterior part of the spinal cord, pain fibers go in a slower pathway along the lateral posterior part of the spinal cord. When you stimulate the proprioceptive pathways, only one signal can get to the brain that gets processed, and that's the gate control theory, essentially. So By stimulating the proprioceptive and vibration pathways, you essentially block pain, but not all pain, just chronic pain. Chronic pain is kind of defined as pain that's been there longer than 3 to 6 months, has become stable, and in fact, part of the neural circuitry. So you actually develop sort of neural circuitry like memories, just like you'd form a normal memory with chronic pain, whereas with acute pain, which is less than 3 months, it's something that is just a direct response. So chronic pain becomes more of a memory as well as a pain type of thing. So it's what the gate control theory essentially does is block that chronic pain. So if you have a stimulator in and it's working very well for your chronic neuropathic pain, but you step on a nail, you're still going to feel that the same as you would normally. You'd feel the nail pain, you would feel the pain that really caused to you, and you would respond to that. But the chronic pain is what it kind of keeps under control. And what's been found over the years is that it's a very robust and stable kind of pain control. So it's not like medications where you start needing higher and higher doses to get control because your body adapts to it or adjusts to it. So it is a very stable, minimal, low side effect way to do things. And over the last 50 years, basically the theory has led to evolution of hardware and technologies that take advantage of that. So with any kind of electrical stimulation, there's 4 main parameters that are involved. There's the voltage or amplitude, depending on which way you're going. And voltage is, the electrical activity, but current is what actually has the effect. So in general, when you're stimulating in the brain or in the spinal cord, it's better to do it based on current than in voltage, although most of the earliest systems actually until the last 5 years or so were all voltage because it was too hard to control current. And the difference I'm sure you guys all know this, but I had to figure it out. The difference between voltage and current is that it's the density with which the voltage goes through the tissue is the amount of current that's delivered. So in different white matter versus gray matter, there's a difference in density. In different layers of the spinal cord and brain, there's a difference in density. So if you're delivering current, then what you're delivering is exactly what you're getting an effect for. If you're delivering voltage, it's directionally accurate, but not 100% accurate with what you're delivering, and can vary to some degree based on the density. So just a little sidebar on that, but basically there's voltage current is one parameter. There's amplitude, which is the size of the wave, which has an effect on the spread of the lesion, the electrical, we call them electrical lesions because they're reversible, but they essentially create a reversible, scalable lesion for the area that you're going through. That's the amplitude determines the spread. The voltage or current determines sort of the height of it along the electrode. And then the frequency, which is how frequently you do it, ties with how effective it can be. So, for example, in the brain, when you're in a nucleus, for example, like the subthalamic nucleus, there's a certain firing rate. It's about 36 cycles per second of the neurons. When you're right at that firing rate, you drive that nucleus to do more. When you're above that firing rate, you create action potential fatigue and you shut down some of that activity. So with electrical stimulation, you can either drive an area or you can decrease the activity of that area depending on the pulse width or the frequency that you use. Because if the frequency is synchronous with what the neurons would normally do, it drives it. If it's asynchronous, particularly if it's higher by a lot, then that slows things down. So there's voltage or current, pulse width, frequency, and then there's the electrode combination. Those are the main parameters with all of neurostimulation. But back to the history, Shealy was the first one to take this technology and start to use it in the intraspinal space. And again, the treatment was around chemicals, cocaine, morphine, things like that, for cancer pain at the time. That's why people did intraspinal invasion with neural implants. So that's where he went with, was spinal cord stimulation for cancer pain. He had an intradural location for his, which was, the trouble with that is with the spinal fluid, there's contact, there's not contact, pulsatile with the heart rate and other things. And also it's more dangerous. Eventually that evolved to different technologies. At this point, there are just a number of different types of electrode combinations for different reasons. But again, it's electrode combination, voltage, frequency, pulse width, that are your variables that you can use to control symptomatology. And in general, with spinal cord stimulation, it's kind of like buying a car. And again, I'm telling you how I kind of tell it to patients because it just makes it simpler for me and them to understand. So with spinal cord stimulation, just like with a pump, you get to road test it first, like buying a car. So there's always a trial period. And with spinal cord stimulation, that's generally with the percutaneous leads that you see on the screen that are put in through a small needle, just like an anesthesiologist would do an epidural injection. Put the needle into the epidural space, feed those electrodes up to usually for the lower extremities, the lower thoracic region, and then they come out through the skin. You go home with a little programmer box that's about the size of a small iPhone, and you can turn the voltage up and down. You can change some of the other parameters within a range. They can't control it as much as you can as the clinician, but they have a little bit of a range to change some of the parameters to try it out. Typically, people go home for about a week. They try it out, and then they come back and it gets taken out. The goal with that is if there's more than 50% improvement in their symptomatology, and that's a little bit of a subjective thing. So it's also another parameter is if they can decrease their medication needs by 30 to 40% or more, that's also a good indicator. Then that's a positive test, and they're going to be a successful person for a permanent implantation. So the trial period for the pump and for the stimulator is very important. Number one, for people to figure out if it's going to help them or not. And number two, to really figure out, if that's something they want. Once they get comfortable with the idea. As you can see, those percutaneous leads in that box in the middle, these have 4 contacts on them that are cylindrical with contact all the way around. If you look on the right to the paddle leads, you can see that it's hard to tell a little bit, but they have a lot different electrode combinations and orientations. But the most important thing is they're insulated in the back with a plastic covering. So even with the trial, what people will notice is sometimes if they raise up the voltage, they'll get benefit, but they'll also get more back pain. That's because the electrical stimulation is circumferentially going down into the spinal cord, but also up into the muscles. So that even with the trial, people can expect some better symptom control and less side effects with a permanent implantation, particularly with a paddle lead because it's insulated on the back. But it doesn't modify that. If somebody doesn't get 20% improvement of their symptoms, they're not a good candidate. So even though they might say I had, a fair amount of back pain, but I had really good leg control of my symptoms, that's an okay test. But and that's one of the symptoms that will get better with using a paddle lead. Typically, when these do get implanted by neurosurgeons, we typically do paddle leads, whereas when they get implanted by the pain medicine doctors, the anesthesia pain doctors, they'll do percutaneous, typically because they can't do the surgical implants. And again, the major difference between the two is there's much more direct better symptom control with the stimulation with the paddle lead than with the percutaneous leads. And as I said, they are adjustable over time. So when you do get it permanently implanted, with the paddle lead, typically it's a small little midline laminotomy at whatever level you're going to put it in. So again, for the legs, it's usually at the lower thoracic region, cervical spine, usually several levels above your highest level of neuropathic pain. And again, this is primarily for neuropathic pain. So the specific indications would be primarily failed back syndrome, brachial plexus lesions, root avulsions in the cervical spine, things like that. But in the lower extremity, it's neuropathic pain, neuropathy, but also, interestingly, ischemic disease, because with ischemic disease, it's actually the number one indication in Europe is stimulation for lower extremity ischemic disease. It actually increases the PO2 within the tissue in the lower extremities, partly by direct stimulation, causing some effect, but mostly by decreasing the pain to the point where people can be more active, lead to more pumping of the blood through the system like they would with walking or moving their legs, things like that. So it can lead to limb salvaging vascularity. So spinal cord, that's one of the few indications outside of neuropathic pain for spinal cord stimulation. So back to the implanting, typically the device is implanted through a small laminotomy by the surgeon, tunneled under the skin, and then a generator is implanted typically in the tissue. For the lower lumbar, it's in the upper outer part of the buttock. For the cervical, typically where a pacemaker would be in that general region, but it can be a little variable. The other indication for this that I find very helpful is occipital neuralgia. It's just a subcutaneous tunneling above the fascia over the occipital nerve, put a paddle lead over it, hook it to a generator. It does really well for occipital neuralgia, supraorbital nerve for headache pain. A lot of other peripheral nerve indications for this are very good too. The devices in general were very stagnant for a while. It was pretty much tonic stimulation, which means you set a setting, let it run, adjust it over time if you needed to higher and higher current or voltage. And the hardware was pretty much similar. Over the last probably 5 to 7 years, there's been a significant improvement in the hardware with, as you can see from the paddle leads on the right, different combinations, a different mixture of combinations, smaller contact size, laser printed contact sizes, so you can get much more focal into the spinal cord to get much more direct kind of effect. And you can see in that bottom area these sort of voltage patterns of where the stimulation goes. The actual science of how this electrical activity is delivered to different parts of the spinal cord has led to development of much finer contacts so that different parts of the spinal cord, different depths of the spinal cord can get stimulated. And what we found over time is that not only is it really good for leg pain, neuropathic leg pain and arm pain, but also now more axial pain because of this fine delivery of current. So it's been really good for that. One of the bigger innovations more recently is, in addition to the hardware improvement, it's allowed the ability to change waveforms. So previously we talked about, a pretty steady frequency, a pretty steady pulse width to kind of either drive the area or down regulate the area. Now with these intermittent episodic type of patterns, as you can see in that upper graph, you can really start developing a very, it's kind of like going from a black and white TV to a color TV. And then now we're getting to sort of the 4K kind of picture. You can really fine tune down to a point-to-point neural activity within the spinal cord to really start getting the lateral part of the leg without getting the medial part of the leg and different things like that. So the new waveforms have really revolutionized indications and efficacy in spinal cord stimulation. That's really been the last 5 to 7 years. And a lot of times people can have multiple waveforms so that they can have variations. So if they're, running on the treadmill, they might have one set of waveforms. When they're sitting down for dinner, they might have a different set of waveforms for different positional activities or pain. So you can give various options. People can just sort of turn the channel to get different types of stimulation in their own home without having to come back to get adjusted. So a lot of the technology has gone from very gross technology to very fine technology. And the really holy grail part of all that we do with functional neurosurgery is to develop a closed loop system. Right now, most of stimulation, brain, spinal cord, everything is open loop stimulation, which means we do something and then we look at what the effect is clinically, and then we adjust based on what we see on an exam or what's reported by the patient. But with closed loop system, it's sort of like, the furnace and thermostat in your house. You set it for a certain setting. The thermostat senses things that are changing in your home that makes the furnace or the air conditioning come on to get back to that setting. The hard part with, so that's a closed loop system. There's sensing, there's analysis, and then there's affecting of something. So we have affecting, but we don't have sensing and integrating. We are, as the programmers, that part of it by the exam and by us making that analysis and doing changes. Closed loop requires recording something in vivo in that person that can act very quickly, that changes very quickly, and then having a processor that understands that and affects some change. So that, like I said, if somebody had certain settings that they could change for sitting versus running versus something else, internally, there would be either waveforms that would be sensed, or maybe there's some, sensing through the iPhone, through activity or posture or position or something like that. There's a lot of people working on different things to try to find some mechanisms that can easily and reliably be translated into sort of a closed loop system, because that's really the holy grail. Once it automatically adjusts, then you're really getting to the level of recreating what a person had before things went bad. Because as long as we're still adjusting it, there's still that interpretation and affecting of a change. So closed loop for everything we're doing is the ultimate holy grail. So that's kind of, that's a little bit of a primer on stimulation in general. That's spinal cord stimulation. Spinal cord stimulation is for the future heading more into better technology, smaller devices, longer lasting devices. But really the holy grail is the closed loop sensing part of that. So I'm going to move now into functional brain, and then kind of leave some time for questions. So it's very similar in the brain. It's actually a little bit, in my mind, easier in the brain because there's a much more spread out area, much more well-defined structures in the brain that can be affected. But really the key to the brain is the accuracy, the reproducibility and the accuracy. The two things that really led to the advancements in the use of electricity in the brain, neuromodulation, functional neurosurgery, is accuracy of delivery of whatever we want to do, and then understanding of the circuitry and how it interacts so that you know where to go for the most part to get what you want to do. And, the first stereotactic frame was by Horsley and Clark in 1908. The first human apparatus you can see here, but really Spiegel and Weisses were the ones who really turned this into intracranial targeting, mapping, and they used pneumoencephalograms to develop their atlas and tie that all together. Lars Lexell further improved the frame so that it was target centered. And really that's the key to a lot of this, is being accurate to your target within sub-millimeter accuracy, but being able to have the flexibility to move your trajectory to avoid important structures, sinuses, arteries, veins, sulci, ventricles, things like that. In general, when you do intracranial excursions through the brain for anything, whether it's any kind of device in the brain, but particularly for stimulation, we want to avoid going through any peel surfaces. So you want to kind of go in through the cortex through a peel surface, but stay within the brain tissue to your target. So going through sulci, going through ventricles just increases your risk of bleeding because that's a very vascular rich area. So in general, just entering through the cortex at your entry point and staying outside of peel surfaces, other than that, is the ideal trajectory. And that's truly what Lars Leksell made possible, making this a target-centered device that also makes it easier to calculate from, but allowed you the flexibility to pick where you wanted to go. So you could change the angle, change the entry point, and it was really, that was a major revolution in getting this done safely. Just like I talked about earlier with lesioning was in the brain as well as in the spinal cord, where we started with treating disorders. And again, a lot of it was serendipitous. It was, of a stroke in the lenticular striate vasculature leading to improvement in tremors from Parkinson's disease, or and just about any other discovery was usually an accidental thing. Obesity with hypothalamic tumors, things like that. The discoveries of all of the functions of a lot of the structures in the brain were mostly serendipitous through accidental discoveries. But then as those nuclei, as those areas of, so that the center of where you wanted to, the center of where all the circuitry comes together were discovered, then people would start lesioning and they would get some benefit. But again, in the brain, just like in the spinal cord, more so in the brain, because a lot of times those diseases are progressive and evolutionary, because none of these things that we're doing are cures. They're all just to improve function. The lesioning would have an effect at the time, but then it would go away. And that's what was found a lot of times with lesioning in the pallidum initially, followed by the thalamus later for Parkinson's disease, is that it would help for a while, but then the symptoms would come back. As lesioning went on, people started saying, well, let's be sure we're in the right spot before we make the lesion. So we know we did all the planning with the CAT scan or the MRI or really early on the pneumoencephalogram, but how do we know we're in the right spot? Because you can't actually see it when you're in there. So what they would do then is through the lesioning electrode, they would put a little bit of electric current in there to see if they could get a temporary benefit. And a lot of these were all done awake. So if they got the benefit they were looking for with the electrical stimulation, they would know they're in the right spot and they would go ahead and make the lesion. So that was kind of how it went. Lesioning was very, very popular right up until the 1960s when L-DOPA was discovered. And there's the movie with Robin Williams, Awakening, where, there was all of these people that were essentially comatose in their beds in infirmaries and homes for people like that. And then L-DOPA, they started giving L-DOPA, they were up, they were walking, it was kind of a Lazarus effect. So that was such a miraculous drug that lesioning went away for probably about 20 years while the L-DOPA was so effective. And then that started showing the effects we see now, which is there's a time-dependent benefit for that, where you start needing more and more and get more and more side effects, and then it loses its efficacy over time. So, but for about 20 years, there was kind of a dip in lesioning, and the medications were the thing. But then right around that time, there was a lot of technological advances in between there. There was some In the late 70s, there was more focus on stimulation in the brain and what did that do, and some technologies, devices that were made smaller and safer. And then Dr. Benabide in Grenoble, France, was really the first one in the mid 80s to take the concept of, if stimulation works before lesioning, why don't we just do that continuously? And then started working with companies to develop that kind of thing. And really Medtronic was a pioneer in pacemaker technology with electrical stimulation. That there was kind of a 20-year journey that went from stimulating, a pacemaker, having a whole cart that carried all the mechanisms and the batteries that went around with the patient, to make it an implantable device. And they kind of took the technology they had for pacemakers, made it a little bit more, made the electrode a little bit smaller and a little more brain friendly than you would for heart devices. And then worked with Dr. Benabide to really start taking an electrode, putting it in the brain, that would stay there, not be inflammatory, not be destructive, connected to a generator very similar, almost exactly the same as what they use for the pacemaker, and then change the parameters and do that. And Dr. Benabide really pioneered that kind of technology. And really a lot of that work was built, again, out of lesioning in animal models, and then creating a Parkinson's model and testing the DBS. And that was really a big driver of getting that approved. So a lot of animal model studies to test it out, test the theory out, and then get to humans. But again, with deep brain stimulation in particular, because it's non-destructive and adaptable, it really does give benefit that makes it safer to test with. So really 87 is when Dr. Benabide did this first. By 1991, it was FDA approved. Deep brain stimulation was FDA approved in the US for unilateral ventro-intermediate thalamic placement for essential tremor. The trouble with that, and that was really good, but it took off really well. The trouble with it was, it's nice to have one hand that works, but there's about 20% of your fibers that cross over, so you still don't get the full benefit without bilateral stim. Plus, it's usually a bilateral progressive disease. So within about 2 more years, it got FDA approved for bilateral placement and subthalamic placement for Parkinson's disease. And then by 2001, it got a humanitarian device exemption for dystonia, which just means you have to have an FDA sponsored study kind of thing in your institution to do it. But those were the 3 main indications by 2001 that were really taken off. But there's about a 10-year run of Parkinson's and essential tremor that really got this to be kind of a mainstay. And initially, deep brain stimulation was at the very end of the treatment algorithm because it was brain surgery and people thought it was more dangerous than drugs. But actually, what we found was that actually it was safer than the medications after a certain point, and it's gradually moved down into the treatment algorithm, so that at this point, in most practices, if you're taking medications more than 3 times a day and still having breakthrough symptoms or limited by dyskinetic side effects, it's something to consider if you've had the disease for more than about 3 years, because you want to make sure it's not a rapidly progressive Parkinson's type of thing where that wouldn't be beneficial. So 3 years of having the disease, taking medicines more than about 3 times a day and still having side effects, you're a good candidate to at least talk about it. And so it's definitely moved down in the treatment algorithm. And what we found is that helps keep people more functional, because if we catch them earlier before they get more debilitated, they stay functional longer. There's also some evidence to suggest that this, by catching it earlier, it can actually slow down the progression of the disease. It's still not clear that's accurate, because it may be just that because as the disease progresses and the electrode's in place where it controls all of that area, just by changing the electrode combinations, the pulse width, or the frequency in the generator, you can recapture symptoms. And when you recapture symptoms, that may seem like the disease isn't progressing. But when you turn the stimulator off, it is progressing. So that's where there's a little confusion of whether it slows down the progression or it's just the fact that it's in there and it can keep the symptoms well controlled even as the disease progresses, That's why that's not clear. But the beauty of it is there are over 64,000 different combinations of settings in that little microprocessor that you can set with the electrode and make. And essentially what we do, I talked about it a little bit earlier, is depending on the electrode combinations, the voltage or current makes that coverage area longer through the nucleus. So the electrode goes through the long axis of the nucleus. So it makes it longer through the nucleus as the voltage or current. The amplitude makes it wider, and then the frequency determines which neurons you're stimulating. So you can really shape it to get what you want to get controlled and get really good benefit that way. Most of what we do is invasive stimulation. Transcranial magnetic stimulation has really taken off, particularly in the last 2 years in the psychiatry world. It's got a better than 70% improvement rate or cure rate with medication-resistant depression. So psychologists and psychiatrists are using transmagnetic stimulation for depression in a very big way these days. We don't generally do that. That's more in the psych world. But ours is more of the invasive type of neuromodulation. At this point, to bring it all together, there's a bunch of different type of stimulation technologies and uses. So there's deep brain stimulation with a bunch of uses, and I'll talk about a couple of those in a minute. There's spinal cord stimulation, which we talked about. Another advance in the spinal cord pain area is dorsal root ganglion stimulation. And then peripheral nerve stimulation is more of a further out end type stimulation where you put the stimulator right on the peripheral nerve, like I talked about with the occipital nerve. Sacral nerve stimulation for GI issues. We talked about intrathecal pumps. Vagal nerve stimulation. That's another one that the science, the actual science of how it works isn't very clear, but the studies show that it does, with continuous stimulation, improve epilepsy symptomatology, in particular, seizure decrease, but also it has had some role in depression. NeuroPace is the epilepsy implantable closed loop system. It's the one closed loop system that we have. And you can see in the lower right corner, the picture of the NeuroPace device. The processor itself is a part of the skull is carved out, and that processor goes in there. You can see the larger electrode, the sensing electrode on the cortical surface. The more direct, straighter lined electrode with the smaller contacts is the effector electrode, the DBS electrode. So it connects a DBS electrode to a sensing electrode through a processor, senses when you start to get epileptiform cranial activity, and then it will affect stimulation, which will abort the seizure. And that also has been very effective, but still a very gross design. Also, gastric electrical stimulation, hypoglossal nerve stimulation are things that have been done. There's a lot of different things to try, but again, this is a field where just about anything you think you might want to do, you're going to be able to do if you have a good reason for it. And the technology is getting better and better to try new things out. But just to go around the horn on the pictures, the upper picture with the man-like person is the vagal nerve stimulator. To the right is the DBS. Just below that is a standard spinal cord stimulator with the generator in the upper outer part of the buttock. And then over the spine in the lower thoracic area, an electrode in the epidural space. Medial to that is the intrathecal pump. And you can see the pump itself, which is sort of hockey puck sized. And then the little intrathecal catheter that goes through the spinal fluid space. Lower left corner is the sacral nerve stimulation. And you see those little electrodes down in the sacral nerve area hooked to the same kind of generator that you have for the spinal cord. In the middle lower is the dorsal root ganglion electrodes that go right out the foramen along the dorsal root ganglion. And then, as I said, in the lower right is the NeuroPace. Overall, that number is an old number. There's probably about 180,000 people now with DBS implants worldwide. It really is one of the few neurosurgical interventions that we have that's supported by level 1 evidence. It's no doubt a better treatment than medications in most scenarios. It's very effective. It's reversible. It's adaptable. And with the deep brain, this is just the entire setup. So there's the electrodes in the brain. There's an extension cable, and you can see just above the ears, there's a connector for that. That's a more robust cable, so that when people turn their neck and move over time, it has more robustness to it, so it won't crack like an electrode would if it went all the way down. And then the generators. There's primary cell batteries, generators, which have primary cell batteries that usually last between 1 and 5 years, depending on the voltage requirement. There's now rechargeable batteries that last between 15 and 20 years, 15 for most of the brain applications and 25 for the spinal. Just below that guy is the charge density relation to voltage that I talked about a little bit earlier, that really, current is really what we drive as opposed to voltage when we're doing these effects. Nobody really knows exactly how deep brain stimulation works, whether it's on the axons or the neurons, but in general, the higher the setting, unless you're, like I talked about before, if you're at the frequency that the neurons in that area are firing, you're going to drive it to do more of what it's doing. If you're in the frequency that's higher than that, you're going to slow it down. So I'm just going to get the next slide. So, sorry, this slide kind of explains what I'm talking about. In the brain, there's the Cortico-Striato-Pallido-Temporal cortical loops. So these loops are neural loops in the brain that are circuits, and there's roughly 6 of them, 4 motor and 2 limbic, and they all interconnect with different nuclei in the brains that are kind of relay station. So the way I kind of explain that to patients is it's kind of like, a train that has a route, and the track is kind of a circular track, and it has a couple of stations on it. So it'll let people off at one station, pick some people up, go to the next station, let people off and come back. And it has a time that it goes to stay on its schedule. And then there'll be another train with another track that kind of connects at one of those stations. If those trains aren't on their synchronous cycles, then the passengers can't get off the one train at the station to get on the other train. That's what happens in the brain. The circular cortical loops, if they're asynchronously working, then the one gets overactive and then creates some adverse effect. So in the subthalamic nucleus, because there's less dopamine in the substantia nigra, there's less inhibition of the subthalamic nucleus, which then makes it overactive, which leads to rigidity. By putting an electrode into the subthalamic nucleus, which is it's kind of almond shaped and about 8 millimeters in size. By putting an electrode along the long axis, we can usually get 2 or 3 of those silver contacts in the nucleus, and then one above, which hits some of the pathways that control tremor. And by doing that, we get then total control of that nucleus. And then by changing the electrode combinations and the voltages and things, we can down-regulate that to sort of slow down the train that's going too fast and get those circuits to be synchronous again. So that's my patient way of explaining how this kind of works. It kind of gets the circuits going the right way that they become synchronous again. It's a similar thing, as you can see from the slide, with the limbic system and obesity. There's a reward circuit. There's the homeostatic circuit through the lateral hypothalamus, the reward circuit through the nucleus accumbens. Those are the main relay stations, but they interconnect. And there's in the ventral tegmental area, there's an interconnection between both of those circuits. At the nucleus accumbens and at the lateral hypothalamus, there's an interconnection between those circuits. So a lot of the research we're doing is around that circuitry and others, Casey Halpern, who's now at Penn, and some others, looking at those different circuits to how do we get that circuitry back and figured out and in control. So that's what's kind of cool about what we do is it really ties to computer technology, and the computer technology is getting so much better that I think, we're really on a good path for the next 20 years to really create a lot of closed loop systems and make this better. This is just I'm going kind of longer than I wanted to leave room for questions, but These are the comprehensive indications. The upper ones are the FDA approved ones. The lower ones are the ones that people are looking at, more experimental kind of things. Two, I want to highlight. One is, back. Oh, going crazy. Two, I want to highlight. One is this one, the deep brain stimulation of the fornix area. This is the original publication by Lozano's group in Toronto. Mike O, one of my old partners, was up there for a fellowship when they were doing this. They actually were trying to stimulate the hypothalamus, which is something that Mike and I had been working on here before we went there. And then they were a little too medial, got the fornix, and found that they improved memory. That's led to a whole company. And now there's a study called ADVANCE-2, which is a study, there's a phase 2 study looking at stimulation of the fornix in early Alzheimer's to look for improvement of function. So that's something that's kind of moving along with really pretty good evidence so far at a phase 2 level study. This is timing at the same time when there's just tremendous interest in Alzheimer's disease with a new drug coming out that's very vaguely efficacious, if at all, but a lot of interest in Alzheimer's. So I think this is probably the next one that's going to get FDA approved, is DBS for Alzheimer's, and it's probably going to be in the next 4 or 5 years. Just quickly, the last thing is one of our main areas of research for a while has been deep brain stimulation for obesity. We did a study a while back, and around 2010, we actually started. We implanted electrodes into the lateral hypothalamus, and on the left, there's a picture of the 3 different patients and where their contacts were in relation to the lateral hypothalamus area, which is the yellow area. And basically, one patient fell out of the study. One patient had, when the stimulator was on, would have better eating behavior, but didn't lose weight, had less craving. So it hit the sort of psychological component of eating, but no weight loss. And that was validated that it was truly not just placebo, because when her battery would just run out of gas, when she'd run out of juice, she'd call a couple of days later and say, hey, I'm starting to get those urges again that I had a long time ago. I feel like I want to eat, McDonald's or have Pepsi all day long, things like that. And then I put the stimulator back in, or put it in a generator, and it went away. So she got some sort of psychological component benefit, but no weight loss. But the person pictured here, her electrodes were in slightly a different area in the lateral hypothalamus, and she actually lost 200 pounds over her pre-surgery weight over about 10 years at about 20 pounds a year. Well, about 30 pounds a year the first few years, and then down to about 10 pounds a year more recently now. So we're just getting ready to start a second phase of that study in August with 6 more patients. This was a voltage-driven study, where the next one is going to be with a current-driven, which we think is going to be better and more directed. So that's a thing that one of our big areas of research that we think is promising. So that's kind of my summary. I think the important thing is neuromodulation is here to stay. It's going to be an $8.8 billion global business by 2025. So there's a lot of investment. It's an exciting field. There's a lot to do. So sorry I talked so much. I was kind of trying to give you an overview, but I'll take any questions now.
Thank you so much, Dr. Whiting. That was an incredible talk. So that we have a little bit of more time for questions, we're going to start the next one at 11:05. Without further ado, let's get into it. So Lana asks, being a preclinical researcher, I'm curious if there are specific questions that we can answer in the animal model that would aid translation. Something we can simply cannot do in the human, not ethically at least. What would those questions be? Or are we really waiting for technology to catch up and increase sensitivity and accuracy for delivering current? Is the roadblock for translation on a mass scale an engineering problem?
Holy cow. That's a researcher question for sure. Well, Lana, there's like a million answers to that, but I'll tell you a couple things. One, for us, when we were starting to do the obesity one, there is no animal model for a fat animal that isn't artificially created. So we actually got ours started without an animal model when we first did this. But that being said, I would refer you to Aryn Gittis, ArynGittis at CMU. Her lab is one that we work with. She has a mouse model for Parkinson's, and she uses photoelectric stimulation to stimulate So in the GPI and the subthalamic nucleus, there's an intermingled group of neurons, two different sets of neurons. And when we stimulate them in people, we get some improvement. But when you can preferentially stimulate one group of neurons versus the other, when they're intermingled, you get a much more long-lasting stimulation benefit. So Nestor Tomich, my partner, who you'll hear from in a little bit, has been, and I've been working with Erin. She has an animal model, a mouse model, that stimulates those specific groups of neurons independently. And then there's another sort of, in humans in Germany, there was a study looking at what's called an intermittent stimulation of the neurons at different frequencies that can mimic what Erin does. We take Erin's photoelectric stuff that she can do where it stimulates specific groups of neurons. And then in her animal model, then we'll take those animals and stimulate them the way it's called coordinated reset, which is kind of a way to stimulate that seems to electrically stimulate those specific groups of neurons and give longer lasting benefit. So what she's done in the lab, she's done some animal models to test if stimulation can do what photoelectric did. And now we're going to be doing it. Nestor's going to be leading a study in humans where we take the device we put in, do that kind of program to see if we can get better benefit by stimulating specific groups of neurons in the nuclei. So that's an example in our world how we take an animal model of something we would have never thought of and then try it out in humans. Hope that helps.
Awesome. Great answer. And thank you so much for the question, Lana. Next, Nicole asks, Dr. Whiting, could artificial intelligence help with reaching closed loop stimulation?
100%. Artificial intelligence. So we have the advantage of having Carnegie Mellon right near us. And, the more you can process and anticipate from weaker and weaker signals, the more you can be predictive. So when I talk about closed loop things, most of the signals in the brain that are going to tell you, if you're going to have a seizure or if you're going to feel like you're going to overeat or all those kind of things are vague, mild signals. But the more you can super process weak data to turn it into something meaningful, the more it becomes a predictive analytic. So AI is going to be the key to really closed loop technology in the future.
All right. Next we have from Brandon. For patients with epilepsy, would there be any conditions where VNS would be preferred over NeuroPace? Are there more associated side effects with RNS?
Really good question. That is the algorithm. So the VNS is less invasive, less risk. Usually people pick that as a first line treatment. The RNS is an expensive device, number one, so not everybody does it. But number two, it involves a craniectomy to put that in there and a craniotomy to put the electrodes in. So it's a next level of commitment for that. And at this point, I don't know. And then there's still medications, and they're coming out with newer medications. And actually the ablative surgery for epilepsy is getting better and better and more minimally invasive. So with epilepsy, there's so many competing opportunities to improve that in my algorithm, it would probably be at this point, medication followed by ablative surgery if it's going to give a high chance of benefit, followed by VNS, followed by RNS. Now, my nephew's autistic. He had seizures like crazy. He was never going to be an RNS candidate, but he's a great VNS candidate and got off of all of his medicines with VNS. So I think that's also the patient themselves and what the indications are also a factor. So it's a multifactorial question, but certainly the algorithm is evolving.
All right, and next from Adam, we have following spinal cord stimulation has associated plasticity/modulation been seen in chronic pain networks, which would eventually reduce the need for the stimulator. would this be more likely to happen in an individual that had the transplant during acute or subacute versus chronic injury timelines?
That's an amazing question. So the yes is my answer. So with there, it's not really done in the acute or subacute because it's for chronic symptoms and but that would be a great thing to study to see if you could avert it becoming chronic. So that's not an unreasonable thing to do, but that's not something that anybody's really published heavily on. Once it becomes chronic, it is kind of like a memory. So a lot of times it doesn't go away. It doesn't change it or make it go away. All that being said, though, I've had patients with RSD and other problems where they've had the stimulator 3 or 4 years. You know, the battery runs out. They don't notice a difference. Their symptoms are gone, and I take it out. So I wouldn't say never's never, but chronic pain is usually there, and it's for the long term. But everything you said is really good things to look into.
Awesome. Well, all fantastic questions. Thank you, everyone. Unfortunately, we're not going to be able to get to any more because we need to move on to our next talk. Thank you again, Dr. Whiting. I think we all learned a great deal about the past and the future of neuromodulation. And now I'll hand it off to Josh to introduce Dr. Nestor Tomic.
Thank you all.
Yeah, thanks once again, Dr. Whiting. That was an incredible talk.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.